All right, so let's hit Article
Number 2.
So this is from friends of ours,
It
so
is.
Sarge Takar and Greg Hendy up at Fresno, or as the joke goes, hell no, say Fres yes. Anyway, it's a Clinics of North America paper, as many clinics papers are. This is a pretty thorough review of a topic. It's a little broader in scope than you'd see sort of in a typical journal. The clinics tends to be more encompassing. This is, a topic that we definitely see in emergency rooms. A lot of HIV care is rendered in emergency rooms. These people fall out of systems and through the cracks. And so this is sort of an important thing, and there are a couple of entities in here that you might not be familiar with, so it's worth sort of reviewing.
Interesting paper, actually.
So patients with HIV are subject to all the same types of musculoskeletal disorders as those without. I mean, obviously, if you fall down the stairs, you can break an ankle or break a wrist, but there are a variety of other entities that they get that are specific to them, and so we're going to divide them into a couple of categories. Category 1 is neoplastic disorders. Obviously, if you're immunocompromised because you're sort of along the line in your HIV disease, then you start getting cancers. And some of those cancers can affect your musculoskeletal system. So Kaposi's, we think of it being a skin problem or a GI problem, also rarely can involve bone, usually by local extension. So if it starts in the GI tract, sort of down in the pelvis, it might get into your hip. It's poorly visualized on plain films. You're going to need to do a CT or an MR. MR is probably where you'd like to go in this if you're looking for the detail. And those are the sort of more useful things. And then also there's non-Hodgkin's lymphoma, which can involve the bone marrow in up to 30% of cases. So those are sort of the two main, and there's a nice image there for you of some Kaposi's all purpley looking. Now, in terms of the infectious disease spectrum, sure, they get some of the regular ones, but because they're immunocompromised, there's going to be some things that are going to come to mind that are specific to them. So mycobacterium TB, so the regular old TB, HIV patients are at high risk for primary and for reactivation disease.
See it a lot, actually, in HIV patients.
Right. Around the world, you should sort of take note, not so much in the U.S., but around the world, TB is the leading cause of death for an HIV-positive patient.
Oh, that makes sense.
For direct causes of death. And HIV is the biggest risk factor in terms of magnitude of risk to go from LTBI, latent TB infection, to active TB around the world.
That makes sense.
So this is a pretty important entity among those who are HIV positive. It's mostly spread hematogenously. TB itself, when it's in the bloodstream, is not an aggressive organism. It needs to sort of linger around before it finds a place to make a home, which is why you get Pott's disease sort of at the base of your spine. Those are the slowest moving venous lakes in your body. So if the mycobacterium TB sort of hang around in those venous lakes, eventually they say, all right, if bone is what's for lunch, let's have lunch. And so they set up infection there. And these are generally, sort of speaking, cold abscesses, and there may be a cold paraspinal abscess next to that. Now, upper lumbar segments can be involved and elsewhere, but generally it's down the bottom as shown in this x-ray. It eventually will cause vertebral collapse, and they can have neurologic complications and be more emergent with a spinal cord type syndrome. And MR is the diagnostic modality of choice. So direct bony invasion by TB. Septic arthritis can also occur, usually hip or knee. Again, it's going to be a little slower in terms of its how fast it destroys the joint, but clearly this is a problem and is going to affect their lives. They're not going to be able to ambulate if this is allowed to proceed. And they may have concurrent osteomyelitis and soft tissue involvement. So that's worth understanding for TB. So same way that Pott's disease might have a paraspinal cold abscess, the infected knee might have a soft tissue infection around it. That's sort of atypical for adults in general. Usually you either get osteomyelitis, or you get a soft tissue infection, or you get a pyarthrosis. You don't get the mixture of
It kind of just meanders. It just sort of
here you're getting them
expands
both
to wherever's close by.
Here you're getting them both together. Diagnosis is difficult because if you culture stuff, it doesn't grow out fast. The organism may not be seen because there may not be a high organism burden, and so you might need bone biopsy ultimately to get there. Now, in addition to the typical old TB, they get some funky TB too. I shouldn't say funky TB, they get some funky mycobacterium.
Yeah.
And so the atypical mycobacterium are in there, and they can cause some weird skin and bone problems and musculoskeletal problems and nodules, sort of as described here. And most of the time when we're talking about these, in terms of what are those sort of atypical mycobacteria, it's Mycobacteria kansasi and Mycobacterium haemophilum and some others that are out there. And they can look like, as shown in the bottom of this slide here, they can look like enodosum, except as you've gathered looking at that slide, that's not the typical location for enodosum, which is generally a lower extremity on the anterior shin kind of thing. That's the most common thing. So if you see something that looks enodosum-ish, or as it does in the top picture, where it's sort of got a beefy border and an erosion, looks very chronic but not nice, you might entertain these as part of the diagnostic repertoire. Then there's some other infectious diseases that are pretty typical for them in terms of how quickly they become disseminated. So you or I, if we played with a cat, might get cat scratch fever and get Bartonella Hensley or Bartonella quintana, but we usually wouldn't get disseminated disease, the so-called bacillary angiomatosis, which occurs in an HIV-positive patient. They can get skin lesions that also look like capaces. They can get long bone osteomyelitis, and if you look at these two images that are on this slide, it looks like that femur has just been, chewed up. It looks like someone threw acid on it, and that's sort of a typical picture of a fairly aggressive infection with Bartonella that's been there for some time. Diagnosed again by bone biopsy, and here, fortunately, antibiotics are curative. This also is another fastidious organism. It's hard to grow it out. If you try and culture it, it's not going to go that well.
Which is so, if you see an osteo-looking bone in an HIV-positive patient, just remember there's this one odd organism in addition to the tuberculosis,
right?
Atypical mycobacteria.
Because TB would come to mind. TB should always come to mind when you're dealing with HIV. But maybe Bartonella doesn't.
Well, I think most of us think of Bartonella as just the cat scratch disease, and it's nice to know that to kind of broaden that to realize that in an immunocompromised person, it actually may cause an osteo, and it'll bring that more to mind.
All right, so then we get to sort of chronic bone maintenance, and active people with good nutrition who are doing things don't get osteopenia and osteoporosis, but HIV-positive people, even if they're pretty healthy, will have more rapid evolution of these entities. Part of it is the HIV infection alone, and might be in part related to their nutritional status and some of the other things that are going on with being chronically ill.
And their meds.
But the protease inhibitors also are linked to increased risk. So this means that minor falls might produce fractures that you weren't otherwise anticipating. So be liberal with your X-ray approach.
If you see somebody who's 35 who's had HIV for 20 years and has been on some sort of suppressive therapy, and they fall, worried that they may have actually had the fracture. Having pain.
I don't know if they quite fall into the category of pathologic fractures, but they're like that. The mechanism may not seem like it's one that would have produced a fracture, but you ought to X-ray anyway and think about it. There's also AVN or osteonecrosis, sort of the newer, more in vogue term for it. And this is more common in the femoral head. Its incidence, and I love this number, up to 45 times greater in HIV-infected patients.
Which I didn't know that.
Yeah, that's high.
That's a lot.
That's a lot. So protease inhibitors, lower CD4 count, history of steroids if they've been on it. And there are some reasons why these patients end up on steroids. For example, if they had a CNS-TB infection, that might got them steroids. There are other reasons why they end up on steroids. They might have got steroids for their pneumocystis infection and things like that. Some of them have chronic asthma in addition, so they might be on steroids. And when that's the problem, you get a sort of double whammy effect.
Right, and this is the kind of thing that I can also see them asking a question about. Somebody who's HIV positive on meds comes in with persistent hip pain.
Because it overlaps with sort of other areas that we know. So I think that's worthy of note. Now, in terms of osteomyelitis itself, it's similar to that seen in patients that are not infected with HIV, except for the fact that the organism spectrum's a little broader. So Salmonella, which you normally think of in a sickler, you want to consider here as well. Cryptococcus, Nocardia, Candida albicans. So
which is not stuff we usually think about.
Right, you don't think about those. And then back to Mycoplasma TB, as we said before. Plain films, as always, and particularly with some of these slower evolving organisms, the plain films are going to be less useful because when you talk about looking for periosteal elevation, that's a sign of an inflammatory response. These might be much slower and they don't have as much inflammatory response as a patient. So plain films are not going to be useful. You need to lose something like 30% of your bone density before a plain film will show an erosion or loss. MRI and nuclear imaging are more sensitive. MRI is the modality of choice. And ultimately, to nail the organism, again, none of these things, except for Salmonella, culture out particularly well. So you're going to need biopsy.
Get a chunk of bone.
And treatment's going to be long-term antimicrobials, and they might need debridement with a surgeon might need to get there and hack stuff out for them to clear the infection. Now, in terms of joint disease in the HIV positive, septic arthritis, relatively uncommon unless they have or ongoing IV drug abuse, in which case that's just like any other IV drug abuser where you worry about it. In that case, Staph aureus is the most common. Unusual organisms may be seen in very advanced disease, but it doesn't happen that much. Now, there is one other difference that you need to know about, which is disseminated GC, which we do see in both immunocompetent and HIV positive patients. In the HIV positive patient, it might look a little different. It might be polyarticular instead of just a wrist plus dissemination.
They do with all of the STDs.
Yeah.
They may be an accelerated course of syphilis that usually takes up 10 years, may happen in 1 or 2. Same thing with this. It's not typical. It still has the joint problems, but it's more of them than you'd expect.
You know, a normal person with GC
it's a knee.
in a joint, it's a knee, it's a wrist, it's one. Here it's going to be multiple joints, and they may become disseminated with or without fever with those gunmetal gray lesions on their skin, those sort of frosted gunmetal gray lesions as part of the disseminated GC picture ultimately. They also get spondyloarthritides more than others. There's a higher incidence in HIV-affected patients. There's HLA-B27 associated reactive arthritis, more common. Remember, not everyone who has that inheritance pattern has those things. If you're HIV positive and you have them, you're more likely to get them. And here we have a picture of Reiter's disease with the classic triad of urethritis, conjunctivitis, and arthritis, the old can't see, can't pee, can't climb a tree sort of image. Psoriatic arthritis, also more common. So skin finding is going to be more extensive in this case. Often involves areas surrounding tendons and fascia. They get the enthesopathy or the enthesitis, which is just another way of sort of using a general term for wherever there's bony attachments get involved. So for example, an apophysitis is a subcategory of an enthesitis. But all of those entities are in there for them. And the key thing here, I don't know if someone would ask this question, but it's not a drug we write for that often, but it does seem to work better here. So if the NSAIDs aren't working, you go to sulfasalazine in these patients.
It's interesting that these immunocompromising states have taught us a lot about these disorders that are immune-related. Psoriasis is actually an immune-related phenomenon, and these disorders have shown us that it's much more so than we realized.
So the immunosuppressant agents are problems in these patients, and interestingly, with some of these more chronic problems like the spondyloarthritis and things like this, and one of the themes that comes through this paper relatively consistently for the chronic things is the best treatment for it is make their HIV better treated. So more effective antiretroviral therapy, getting their viremia down, better controlling their disease may help these conditions resolve.
Which is
or
interesting
at least
because it's not the immunosuppressing them actually is, or viral suppressing them takes away the immunosuppressive effect of this particular problem.
Yep. And then there is also a couple of specifically HIV-associated arthritides. It's similar to other viral arthritides. It's transient, non-erosive, lasts less than 6 weeks, which sounds fine when you're reading a slide, but imagine having it for 6 weeks. Synovial fluid analysis is negative, and some of these people are tapped over and over again because you're worried about all those other things that don't grow out. So it's a little bit frustrating, and the treatment there is NSAIDs. There's also this painful articular syndrome, which is different from what we were just talking about in that this is a very sort of hyperacute single joint, 2 joints at most. They get hot, they're painful. These also get tapped all the time, and nothing grows out.
These last two we're talking about, I think, are important to know exist. When you have an HIV positive patient, sometimes they're not, if they've been a drug user, they're sort of labeled as a difficult patient already.
Yep.
And then if they come in and they won't walk, this very well could be that HIV-associated arthritis where they really can't walk. It's not that they're being difficult. And I've seen a couple of cases of this where they've been sort of, oh, come on, get out of bed, get out, walk.
Right, you're depressed.
Right.
People start,
and
let us call psych.
And it's 6 weeks of that. I mean, it's not that they're being recalcitrant. They just, they can't.
Yep, indeed. And then there's the polymyositis, which can also occur. So this can be an idiopathic inflammatory process. There's the subacute proximal thing with an elevated CK. It may be, this is worth knowing about because we're learning sort of these new initial presentations of HIV. So anytime you can diagnose HIV de novo in a patient, obviously it's not great news for them, but it may impact their behaviors and limit spread, and it may get them treatment earlier and prolong their life. So it's really important. So you see zoster in a young man in East LA, they need an HIV test. Why do they have that? So that's an example. You see a retinitis in a young man. or a young woman,
dermatitis.
a bad seborrheic dermatitis, you need
All
to think
10
about
toes
it.
have fungal infection.
Yeah, these are times when you got to start thinking about it, and this is one of those ones. Polymyositis can be the initial presenting finding. You see an unexplained thrombocytopenia. Maybe you need to think about this. So this is a time to send an HIV test. If they're known HIV positive, then you should be aware of it. And it sometimes is associated with high-dose zidovudine treatment, so it may be a drug-related side effect, and it can be cooled off with some corticosteroids. The other thing you need to worry about is that sometimes polymyositis is a sort of a paraneoplastic presentation of a cancer in a more advanced patient with HIV, more advanced infection and immunocompromised. So there's a bunch of things about that, but polymyositis is in there. And then finally, pyomyositis. So deep muscle abscesses, usually Staph aureus. They're more common. They're rare in general, but they're still more common. And you'll see these sometimes in people who don't have HIV as well. For example, you'll see diabetic myonecrosis every once in a while, and it sort of turns into an abscess. But this muscle involvement is something to think about. This is a great image of a leg with a compartment that's obviously got a big infection in it. They get crampy pain. It's along one muscle group, low-grade fevers. There may or may not be induration. All of the ones that I have seen are either in the groups that are listed here, quadriceps, gluteal, iliopsoas, or in the calf. One of the differences between this and the diabetic myonecrosis is the diabetic myonecrosis tends to much more be the calf than the upper part of the leg.
Which makes sense because it's usually coming
It's
from the foot.
Right.
Yeah, and this is actually important, though. I like this slide, and this sort of is a nice take-home. If you take care of HIV-positive patients, if they have what seems to be a muscle cramp in their quads, why would they have that? Why would they have a low-grade fever with that? What's going on? Because your quads are big, and you can put a pretty significant abscess in there
and not know about it. And it's a roomy compartment.
Right.
Yep. The other thing I would just add, and not to be in any way, shape, or form, because I think this is a great article by Greg and Sarge, but there are a couple other things that should sort of be smoldering in your mind when you see an HIV-positive patient who has muscle pain, which is they can get more rhabdo, because we now know that HIV is also associated with accelerated coronary artery disease, and they're put on statins, and they're on these other sort of myotoxic
and more risk
agents.
Of diabetes, both of those.
Right, and that was my second note, which is that if they have diabetes and they're on heart, they may have a higher risk of sort of this combination, part diabetic myonecrosis, part HIV-related
It's almost
deal.
a cruel irony that you have a terrible disease that they can control that makes all the other chronic diseases happen faster.
So an array of some entities that are not quite specific to the HIV population, but certainly they're not the kind of thing you think of it every day, and in this population you should keep them in mind. So the summary: antiretroviral therapy has changed the spectrum of disease. They're living longer, so osteoporosis and osteonecrosis are now more common than opportunistic infections, and they might have something that looks like a pathologic fracture or a mechanism that you don't think should break something, but it did. So x-ray liberally. Spectrum of infection is similar to non-HIV infected patients with a few caveats. If they're profoundly immunosuppressed, you see some other weird things, and we talked about those. And then the non-infectious spondyloarthropathies and myopathies are here in a higher rate. And if you're worried about weird infections, the ones to think about are disseminated Bartonella, TB, and some of those atypical mycobacteria infections like Mycobacterium
Right, so if
kansasi.
TB crosses your mind, just throw in those other two, atypical mycobacteria and Bartonella, and you'll cover those bases.
There you go.